Hi, and welcome to our first review of a paper. So today I want to review this paper uh, on safety of large language models based clinical decision support system in African primary healthcare. I just went over the paper, and it's an interesting paper which has elicited some interesting conversations, and I decided why not review this paper and see how it goes. So it's a recent paper, just published 2 days ago. Yeah, 2 days ago on Nature in Nature Health, and it has some interesting insights with a wonderful list of authors who've prepared for us this paper. So without much further ado, let's dive into the paper. So I think even before I start, this is one of the, let me say, biggest, in quotes, AI use case papers in healthcare that have come across in Kenya. I don't remember if there's any other paper that has looked into AI and healthcare and teased that interaction, and that's what makes this paper actually very unique, and more so a landmark paper within the Kenyan health space and AI. Okay, so let's get into it and see what it has to say. So just from the title, a catchy title, love it, safety of LLM-based clinical decision support system in African primary healthcare. And just to begin, I think the authors go straight into the crack of it by defining where the problem lies within our setting. And obviously, it comes down to the inadequacy of healthcare staff that we see locally. Obviously, there is quite a number of staffing shortages in sub-Saharan Africa, and you want to meet this gap, either one, by producing more clinicians, which economically we've seen over the past couple of years it has been troublesome trying to meet that demand and supply. And now we're having AIs coming through, and the question is, how much can AI fit into this space, and not necessarily to replace, but rather to compensate. And I think that's the more general adaptation of AI in such settings. Yeah, okay. So the paper goes on by saying they acknowledge that AI can provide frontline clinicians with real-time specialties, physician-grade, contextually relevant diagnostic and management suggestions. And that's the beauty with AI. It's that it can condense such a large number of, let me say, content, and make it easily digestible for anyone. And much better so, we've seen that AI works best in the hands of experts. So yeah, let's continue. So let's see the potential of this technology to improve diagnostic reasoning amongst primary care healthcare providers, support treatment planning, and even deliver therapeutic interventions. Yeah, so yes, that's definitely where AI can come in. So I know I've just gone in and I've dived deep into the paper, but one interesting thing when I started reading this paper, I was really waiting to see where the safety aspect comes in, and maybe what do we define by safety? What do we mean by safety of large language models? I think that's something really interesting that I really wanted to see come out from this paper, and just to get a sense of where the direction of research goes with this kind of integration of AI and healthcare in Africa. Okay, great. So the paper goes on introducing the scope, and over here they say in both cases there is a very real risk when naive applications of an NLM to a novel low resource setting means that errors arising from the aforementioned biases in the training data might lead to flawed clinical reasoning or guidance, and potentially compromise patient safety if taken to face value. Now, this ties to the aspect of safety and where it comes in. So the authors acknowledge that, number one, that the use of LLMs can work in healthcare contexts. And particularly in this case, we are more concerned about it being used in low resource settings, such as African primary healthcare settings. But then they acknowledge that there is a risk that is there when you use these LLMs in such settings. And one of the risks is that this LLM has been trained with the data that is not primarily fitting to this context, and it might be tricky on how this LLM is adapted into this context and how much sense it can make out of it, and actually trying to outline the risks that are there. So if you're able to capture the risks, then you know what kind of safety issues that might arise when these tools are used. So over here, or in this figure, what you see is that LLMs are normally integrated into platforms. So instead of using it just from like the way you can use ChatGPT, where you type in and it chats back to you, there is a way you can integrate LLMs into systems, and in this case, it has been integrated into. Let me just get the proper wording for it. It has been integrated into a clinical decision support system. So we have an LLM here, and then you have a clinical decision support system. So when you integrate that, it allows the LLM to serve you within that system, instead of moving from whatever platform you're working into and going to somewhere like ChatGPT where you can type in your query, right? So this is an example of it from this image. So from this image, you can appreciate where the aspect of clinical decision support system comes in, and where the AI integration comes in as well. All right. So this study was done across 16, so over here, 16 outpatient facilities that are operated by Penda Health, a private social enterprise serving urban communities in Nairobi and Kiambu counties. Now, for those of you who have come across Penda Healthcare, you just know it's all over Nairobi. It's a very common and popular, let me say, hospital that very many Kenyans have access to, given their accessibility, given their prices. Okay, no, I'm not advertising for them, but I'm just saying the things I've seen. And of course, it makes sense that this would be a good place where you would tease out where the African healthcare, primary healthcare happens, where African primary healthcare actually happens on the ground. And given the diversity across this populated Nairobi County, and seeing that they have like 16 outpatient facilities, so this gives you variety of what's happening in one side, what's happening over the other side. Okay, great. So it's a level 3A and 3B facilities. Great. So which are 24/7 outpatients and primary care centers, staffed primarily by clinical officers, that is, physicians, and licensed to independently diagnose, prescribe, and manage a wide range of outpatient conditions. Great. So they also mentioned that these facilities are level 3A and level 3B, and they are run by clinicians. And it is important because then you can understand the landscape of primary healthcare in Kenya. In this case, you can understand what kind of personnel the patients expect when they go to such facilities. So again, it can also help you, given that they're level 3A, level 3B, it can help you understand what kind of services that might be offered in these places. So definitely you won't find consultants in these places, unless perhaps it's just a consultant who has, for example, has 1 or 2 let me say visit days per week. But these facilities are primarily level 3A, level 3B, which means they are pretty much constrained to what they can offer, but rather they capture a multitude of those common conditions that happen within a primary healthcare setting. Great. So that's the introduction. The ground is set, but there's something else I want to dive in before we go into the results, and that is the methodology. So I'll just go all the way. This is where they have the methodology. So some of the methodology is some of the things I've talked about when I was introducing, but something interesting that I would like to capture is that this study was done in 2024. So the primary data collection was done in 2024, and it was done on a 3-month period. So it was done between July to September 2024. Okay, so during this time, they saw a number of patients, and they were able to record a number of visits. So the total number of visits that were captured, let me just come here, were around a total of 1,469 patient encounters were the ones that were included in the evaluation. However, there were obviously more than 1,469 encounters. I think there were 36,670 consultations that had happened. However, 14,609, 1,469 were the ones which had an LLM was used for consultation. Yes, and also there's some certain filtering that they did, but it was just a little to get to this 1,469 number. Okay, so keep in mind, in this paper they were working with 1,469 cases. All right, so here it says we drew a proportionality allocated age stratified random sample that of about 1,500 cases. So that's what you've mentioned. So something else is that's on the part of the clinic side. So let us go to the part of the LLM. On the part of the LLM, they used let me say GPT 4.0 model. So they used they used an open AI model. In this case, there are different variants of ChatGPT model. So I think the latest one is 5.1 or 2, not really sure. But in this case, they used a GPT 4.0. Okay, so this GPT 4.0 is the one that was integrated within the electronic medical system for Penta Health, which again goes to show the importance of having an EHR which actually works. Because if you have an EHR which works, that means you can be able to integrate LLM systems. So they use that. I won't go into the nitty-gritty of the hardware integrated to server, and so the most important thing I think here is how they were able to review those outputs that were done by the LLM and clinicians. So in this case, they used 4 physicians who independently scored the records to see if they met the safety threshold or did not meet the safety threshold. So over here we have the evaluation procedure, and they go ahead and say from 1,470 cases in the evaluation dataset, we exclude one routine follow-up, leaving 1,469 encounters. There were a total of 1,880 LLM generated responses for the 1,469 clinical encounters, indicating that in a minority of cases, the AI consult tool was used more than once in a clinical encounter. So this means that out of the cases that they used to in this study, we had more number of AI consultation compared to the encounters. So that means that some clinicians even prompted the AI more than once. Yes, obviously more than once, so that they can get a response. So the outcomes that these 4 physicians in this case were interested in. So they were interested in the quality of the initial document. They were interested in the appropriateness of any diagnostic reasoning. They were interested in the appropriateness of any clinical reasoning, including post-investigation and treatment planning. and then they were interested in the safety of the LLM's recommendations and whether both potentially harmful and beneficial recommendations appeared to be acted upon. So this was the primary outcomes of interest in this study. And under safety, I haven't done a very good job, a stellar job in defining it, but here, they say for binary and nominal outcomes, including the presence of unsafe advice. So they were in terms of the safety of the LLM, they were looking at unsafe advice, number one, hallucinations, whether there was evidence of diagnostic reasoning, and provision of reasonable differential diagnosis. And they used Fleiss-Kappa score to score this metrics. So the importance of this bit, or the importance of this methodology, is to ensure that anyone else can reproduce whatever they did. And if you go deeper into the methodology and look at the statistical analysis, you'll be able to appreciate how they turned this kind of descriptive or qualitative study in nature into something more methodological that you can easily review, you can easily replicate. So just to go back, you see here they say we use, number one, descriptive stats to summarize the data for reporting, and then we calculated exact binomial 95% confidence interval for all proportions of evaluation metric across the quality and safety domains. And then they went further to look at the ordinal outcomes, including the quality of initial clinical documentation, whether the LLM addressed identified issue, alignment with patient context and clinical modification of documents, and reduction of identified risks. We calculated Kendall's W statistics to quantify agreement among reviews. So even though they had 4 physicians reviewing the LLMs to clinicians' responses or output, in this case the LLM's output, those reviews were independently passed across the physicians, and then they looked at the interviewer. Let me just get the proper word. The interviewer, let me just get it. Yeah, so they looked at how different, how the reviewers performed in each of the review. So why am I missing the word for this? Okay, yeah, right here. So in determining whether a clinician's change was attributed to the LLM, evaluators classified revisions as LLM induced only if it aligned with specific content in the LLM's output and diverged from the initial document. Any changes that were inconsistent with or unrelated to the LLM suggestions were classified separately. So again, they were not permitted to discuss cases with each other to avoid influence, but they could query the study coordinators or investigators if any patient record data was unclear. So that's how they had, I'm assuming in this case, they had the 4 physicians not interacting so that no one can influence the other, so that you can get at least, let me say, standard scores that can be able to be reproduced. Yes. So the word is here, inter-rater reliability was assessed. So let me just highlight that. So over here, inter-rater reliability was assessed on a subset of cases that were duplicated and independently reviewed by 2 evaluators. So I guess even after these 4 clinicians had done their pass, there was inter-rater reliability that was assessed. So that's the word I was looking for, inter-rater reliability. Great. So that is on the methods. We are set on the methods. So we have an introduction. Let me just go over again. We have an introduction. We are looking at safety of LLMs used in a primary healthcare in an African setting. And in this case, it has been integrated in a clinical decision support system. So that's number 1. Then number 2, we see that this clinical decision support system is being done by Penda Health across 16 facilities within Nairobi and Kiambu. Great. Then they go into the methodology and explain that they are doing this with the help of physicians who will be reviewing the output of the LLMs. And in this case, we had around 1,469 encounters. And in this case, it's the clinicians who are handling this. And we even had more AI consultations, that around 1,800 and something. So that sets the basis of the research. And in this case, we are really concerned about the safety of the AI in terms of their recommendation, whether they gave unsafe, let me say unsafe discussions, is the word, whether they gave unsafe advice, whether they hallucinated, and their evidence of diagnostic reasoning and provision of a reasonable differential diagnosis. Great. So in the results, let me just go into the results section. Okay. So in the results, I'll just go over some of the interesting bits. So number one is you get to appreciate the wide range of conditions across respiratory, which was the highest with 38%, GIT cases, and dermatological, musculoskeletal, and so on. Then the most common safety concern, so probably this is where you've been waiting. The most common safety concern was inappropriate medication in 272 cases. Okay, so omission of critical differential diagnosis and incorrect diagnosis. So in terms of safety concerns in which the AI gave, these three ranked the highest: inappropriate medications in 272 cases, omission of critical differential diagnosis, and incorrect diagnosis. So for the first one, it had 272 cases. The second one, in omission of critical diagnosis, was 230 cases, and in the third one, it was 120 cases. All right. So it goes on to show some of the areas in which the AI gave, for example, unsafe dosing, inappropriate investigations. But this goes to highlight how much the AI can still be wrong, even in such cases. Okay, so safety concerns were less common when initial documentation was high quality and rose as quality declined. So that's something else that is very crucial, is that the AI did a poor job in this case when the documentation was deficient to some extent. So less documentation, poor scoring with the AI. Greater documentation, a much better score with the AI. All right. So in terms of appropriateness of the LLM-based outputs, we'll focus on hallucinations in this case. And here it showed that in around 50 responses, the LLM hallucinated. So in this case, the LLM will probably, by the time of hallucinations, that LLM will probably say something that it's not supposed to say, or probably make a guess that is totally wrong. So in this case, for example, FGC, which is, you'd probably write as fair general condition, the LLM interpreted it as female genital circumcision. So that was totally a big hallucination. Anyway, so something else that they looked at is the diagnostic reasoning of the LLM. And in this case, it demonstrated well reasoning, considerations of alternatives, and also had it gave different differential diagnosis. But it's saying out of 1,416 cases, 223 cases, that is 15%, had partial or inappropriate differential diagnosis. Okay. And then it also contained major reasoning gaps or misleading information, such as inappropriate reassurance about granulocytosis or missing pregnancy tests. For example, this was in a 28-year-old woman with high right lower quadrant pain, and 2 other responses, and only 2 responses. Okay. So, and only 2 responses were determined irrelevant. All right. So in this case, we're seeing in terms of reasoning is that the LLM wasn't obviously perfect. It had some shortcomings. And the shortcomings were showcased in terms of, in some cases, it had a good reasoning, but in some cases it had inappropriate or incomplete differential diagnosis. In some cases it gave misleading information or inappropriate reassurance, right? So some other thing is that, so this is an example of a clinical case where it was in a 25-year-old woman that they initially diagnosed with acute rhinitis, but the LLM identified an recognized microcytic anemia and suggested iron deficiency as possible comorbidity, with which the clinician subsequently incorporated into the final documentation. So this is a case where I think it flagged something positively, just to showcase that sometimes the clinicians might overlook something with which now the LLM can flag. So this was actually one of the positive encounters. Okay. Okay, next, it was clinical reasoning. In clinical reasoning, appropriateness of the LLM response in the patient's socioeconomic, cultural context, or resource limitation was high, with no conflict in 1,153 encounters, which is very good. It shows that LLMs can probably figure out or can put into consideration the patient's economic status and some of the things that surround the patient, because you don't want to look at the patient as just a person walking in with a disease. There is a whole lot of things to consider in this case. So safety concerns associated with LLM outputs. So in terms of outputs, overall, 115 responses included active recommendation that evaluators considered potentially harmful and were guided to have posed major safety concerns. So this is in terms of concerns. Sometimes the LLMs can give outputs and they might define the Hippocratic oath of do no harm. So in this case, I think out of 115 responses, LLM actually gave an output that would lead to harm. All right. So interesting results actually all through. So if you can get time, just dive in and see at how the LLM responds differently. So the most common potentially harmful LLM outputs were inappropriate medication recommendations, noted in 54 cases, omission of critical differential diagnosis, and incorrect diagnosis as well. So after all this, the question is, we have an LLM, it's hallucinating, yes. It's giving some inappropriate diagnosis, inappropriate differential diagnosis. But in some cases, it's actually flagging things, it's actually giving proper recommendation. But the real critical impact in this case is then how do clinicians respond to this? How do they act based on this information? And here it's where we have this paragraph where it looks at clinician response to LLM recommendations and impact on patient safety. All right, so in this case, they say in most encounters, clinicians made no LLM-induced changes. We had minor LLM-induced changes. For example, they give an example of a 2-year-old with a short history of cough, sneezing, and running nose was correctly diagnosed with a viral respiratory infection. The LLM did not alter the diagnosis or overall management, but made small documentation refinements. Okay, great. So now this goes to show the interaction between the LLM and the clinicians. Okay. Then it goes on. In 194 encounters, the LLM induced major changes. For example, in a child initially assessed for cough, abdominal pain, the original documentation lacked any bowel-related diagnosis. After the LLM highlighted chronic fecal soiling and the possibility of functional constipation, the clinician added a diagnosis of encopresis, performed an annual examination, and instituted a full management plan, including laxatives, dietary advice, and tolerating routine. Among the 552 encounters with any change, edits most often encountered the treatment plan. So most of the edits were around treatment plan in this case. Okay, can't get this document. So most edits are around treatment plan. Followed by differential diagnosis, and history or examination findings. Okay, so we see that LLM gave recommendations, and to some extent the clinicians acted upon them. But however, in 420 cases, which is a lot, clinicians continued with the potential harmful cause of action identified in the initial documentation, despite the LLM explicitly providing helpful guidance in 362 cases. So this is one interesting bit. We see here, okay, let me go to the top. In 803 encounters, no risk was initially identified and no new safety concerns were introduced. However, in 420 cases, clinicians continued with the potential harmful cause of action identified and initial documentation, despite the LLM explicitly providing helpful guidance in 362 cases. Apart from the aforementioned 115 cases of the LLM-induced harmful action, there were another 13 cases of spontaneous, not LLM-induced, changes to the final documentation that introduce risk to patient. So this is actually an interesting bit, and it goes to show how humans and AI interact, especially in the clinical space. And in this case, we see that in 420 cases, clinicians continued with the potential harmful cause of action identified in the initial documentation, despite the LLM explicitly providing help guidance in 362 cases. So I think one important thing is it goes down to show how much, let me say, education or training is needed, because if an LLM spots an issue and you continue despite it spotting that issue, I think the best course of action here would be to maybe refer or consult in this case. And it's something that happens a lot in primary healthcare settings, whereby you have an issue you can't solve and you don't have anyone to consult with, or any place to refer to. So I'd be interested to see the dynamics of these cases. On were they cases that actually needed referral? Were they cases that could have benefited with consultation? And in this case, maybe the clinicians might have assumed in this case and went with their judgment and just probably thought that LLM wasn't really correct or accurate, and by therefore making an error on their side. And this goes to show where or how the interaction between an LLM and human how far it can go, where the limitations exist, and something that actually needs more research and see how things go in the future. So it goes on, and then it says, apart from the aforementioned 115 cases of the LLM in use harmful actions. So this time the LLMs are the one who are providing now the harmful recommendations. There are another 13 cases of spontaneous, not LLM changes to the final documentation that introduce risk to the patient. So in this case, we see LLM providing like harmful, let me say, options or advice, and people still picking it up for one reason or the other. Okay, great. So the paper is actually very, very interesting, and it goes further to the discussion. This is an example of a case that highlights the unsafety of the LLM and so on. All right. Yeah, so that's where I'll stop for today. But this paper is actually very, very rich. There's a data set available, which is, I think, my next course of action. I've downloaded the data set, which is available in this link, just to play around with it, and to see what I can do, get more insight of the paper, read the paper, and see where it goes. Yeah, I think that's all for today from me. Until the next review, bye bye.